Okay, so today's topic is about radiological anatomy of the cranial nerves. So there is nothing to disclose. I would like everybody to log into this website www.menti.com and use the code 177073364. So that's why I asked everybody to log in. So I'm starting with the question. So what is the specific MR sequence for imaging cranial nerve? Because we are studying cranial nerve today, and on imaging, what is the specific MR sequence for imaging cranial nerves? Is this diffusion weighted sequence, SWI, steady state, free precession, T2 weighted, or T1? So I can wait for 30 seconds. There is no harm in trying if there are medical students. So everybody is going into the middle. So I am now starting countdown, and you can look at your phone and type the answer. So you have 30 seconds to type the answer. And time's up. So the correct answer is steady state free precession. I think nobody has written their names when they were answering the question. Okay, actually you have to choose the answer from the options. Don't write the different answer because it's just a robot, it's just a computer, so it will just take up the answer which was written in the answer sheet. So the correct answer is steady state free precession. Oh, so people have written their names. So a steady state free precession sequence it's basically a radiological term. For the non-radiology people, you can understand that it's a very easy sequence for the scanner. Like it does not take too much time. It has a high T2 T1 ratio. That's why it can detect cranial nerves which are running in the cisterns against the CSF or the white background. But different vendors have different names for it. Like these are academic classification. Most of the residents who are working at AKU, they know the CIS sequence. CIS sequence is also the steady state free precession sequence, but different vendors call it with a different name. Some call it as SS, FP, GRASS, Fiesta. In old scanners, it was known as heme sequence. But when actually you are evaluating the cranial nerves, not only the steady state free precession sequence, but you also need other sequences. Like for the T1 weighted sequence, it's used for the anatomical definitions. When you are looking at any lesion along the cranial nerves, then invasion of the fat planes and denervation changes in the muscles, which you can see in the T1 weighted as well as in the T2 weighted sequence. But T2 weighted sequence help us in lesion characterization and patency of CSF spaces. Diffusion flare sequences are used when we are suspecting any lesion at the origin or at the level of the nucleus of the cranial nerve for the ischemic lesion. Post contrast sequences are helpful when we are looking for the enhancement of the nerve, like in Bell's palsy, any perineural spread of the lymphoma or perineural spread of the tumors. When we are talking about cranial nerve, CT scan is equally important because the cranial nerves exit through the foramen, which are in the skull. So, like the cribriform plate is related to the olfactory nerve. I don't want to go into the detail because it's just an hour presentation. But CT scan, always remember the exit foramen of the cranial nerves because it's also important, equally important for the evaluation of the cranial nerve. So let me give you some general concepts. It's equally important for the medical students and for the consultants as well. Like the nuclei of all cranial nerves except 1 and 2, they are located in the brainstem. And that's why they are not myelinated by the Schwann cells. And from the origin, nerves are divided into cisternal, intracranial, and then extracranial segments. So this is the olfactory nerve. The thing which is important for the olfactory nerve evaluation is some people misinterpret olfactory nerve from the gyrus rectus. So that's why the tip for the evaluation of the olfactory nerve is always look on the T2 coronal sequences, where you can see the olfactory nerve just below the gyrus rectus. And if you magnify the image, the olfactory nerve is between the gyrus rectus and the medial orbital gyrus. The second cranial nerve is the optic nerve. It has 4 segments. And the important thing about the optic nerve is it has a retroorbital segment, then the intracanalicular segment, then the prechiasmatic segment. The thing which is important, like you have to remember the structures around the chiasm and its relation to the pituitary stalk. The segment which is mostly overlooked, that is my second question, and then I will tell you about its answer and its further explanation. So again, log in and see which segment of the optic nerve should be screened for vision loss. Is it orbital, canalicular, retroorbital, cisternal, or retinal? Which should always be screened for vision loss. So the correct answer is canalicular. Good. So we have 3 winners. So the tips for the evaluation of optic nerve is we should know there are four anatomical segments like the retinal, orbital, canalicular, and cisternal. The canalicular segment is important because it's frequently overlooked on radiological images, and it should be specifically sought when imaging is for visual loss. And the canalicular portion is the segment that lies in the optic canal and it is below the ophthalmic artery. So like I always do it, and that's why we acquire volume sequences so that we are able to see all the segments of the optic nerve. The cisternal segment of the nerve can be visualized in the suprasellar cistern, and for that you don't really need cis or the steady state free precession sequence, because you can easily see it on the T2 weighted segment. uh, it is the area where the nerve leads to the optic chiasm, and the anterior cerebral artery passes over the superior lateral aspect of this external segment of the nerve. And the key anatomical landmarks, as I have already told, is the infundibulum, pituitary stalk, and the anterior cerebral artery, and posterior to the optic chiasm are the mammillary bodies. So again, there's a question. So name the cranial nerve which is marked by arrow. Is it oculomotor, olfactory, abducent, trigeminal, or the optic nerve? I can show you the image again. Now you have to type answer. And the correct answer is oculomotor nerve. Okay. So this is the oculomotor nerve. You can easily see it or review it on the MRI on the steady state free precession sequence. Like it's in the at the level of the interpeduncular cistern, it goes straight and then it enters into the cavernous sinus. But on the coronal sequences, you can see one more important landmark, which is how it runs between the posterior cerebral artery and the superior cerebellar artery. So always remember this relationship of the oculomotor nerve to the posterior cerebral and the superior cerebellar artery, but you can see it on the coronal sequences only. And how to evaluate the oculomotor nerve at the level of the brain stem and at the level of the interpeduncular cistern. It's very important to detected on the MRI, because if you are looking at any pathology of the oculomotor nerve, then if you are searching it at the level of interpeduncular cistern, then you can easily find the oculomotor nerve. So again, it's the same things which I have already told you, that the oculomotor nerve emerges into the interpeduncular cistern And this root entry zone is a good way to identify the nerve on the steady state sequences. And in the prepontine cistern, it runs between the superior cerebellar and posterior cerebellar arteries, which makes it easy to identify on the coronal images. But you can see it on the volume images of the T2. For that, in the coronal plane, you don't really need a steady state sequence. The cavernous segment of the oculomotor nerve runs along this is also an important point. Like, what is the relationship of the oculomotor nerve within the cavernous sinus? It runs in its lateral wall, and it's the most superior occupant of the cavernous sinus. And then it enters into the orbit through the superior orbital fissure. The fourth nerve, which is the trochlear nerve, it's the only cranial nerve which arises on the dorsal aspect of the brain stem, and then it runs along the two leaflets of the tentorium. And that's why it's always said, for the especially for the radiologist, like if somebody has asked you for the evaluation of the trochlear nerve, isolated trochlear nerve abnormality, pay attention to the dural layers, because something might be there in the dura which is indenting, or which is involving the trochlear nerve if there is isolated involvement of the trochlear nerve. So the trochlear nerve rises dorsally along the two leaflets of the tentorium, and then it runs anteriorly, and then it enters into the cavernous sinus. So again, there's a question: name the cranial nerve marked by arrow. Is it trigeminal nerve, oculomotor nerve, abducent nerve, glossopharyngeal nerve, or the vagus nerve? I can show you the image again. These are two cranial nerves which are marked by arrows. So what is the name of this cranial nerve? Yeah, the correct answer is trigeminal nerve. Who is Ashley? Hamza is also going good. So this is the trigeminal nerve. Trigeminal nerve rises at the level of the pons. Then it runs, it's the largest cranial nerve. Then it runs anteriorly and enters into the Meckel's cave. This is the axial image, and this is the coronal steady state sequence, or you can call it cis sequence because we have cis sequence in AKU. So Meckel's cave is like, if you see it on a high resolution MRI, it's just a meshwork of it's a meshwork in the Meckel's cave. So after traversing the Meckel's cave, it forms a ganglion, and then it divides into the three cranial nerves, three segments, sorry. So the ophthalmic and maxillary divisions of the nerve run medially into the cavernous sinus, and they exit the skull through the superior orbital fissure and the foramen rotundum respectively. The mandibular division is a different one, which includes the motor branches. It exits the skull inferiorly through the foramen ovale. It does not enter into the cavernous sinus. So again, there's a question: which cranial nerve uses this foramen to exit? For that, you need to know what is the name of foramen and and the segment of the trigeminal nerve which uses this. So the options are ophthalmic, mandibular, maxillary, olfactory, and abducent. And here is the image. Which cranial nerve uses this foramen to exit? Yep, it's mandibular. Good. So the sixth nerve is the abducent nerve. Sorry, I'm going very fast because I need to complete these cranial nerves in this session. So the sixth cranial nerve runs anteriorly from the pons, and then it's enter into the duralis canal. But when it is crossing at the level of the cistern, it is crossed by an artery which is in an orthogonal plane. And when and after that, after traversing through the cistern, it enters into the duralis canal, and then it enters into the cavernous sinus. So abducent nerve is an approximation to which artery? Is it anterior inferior cerebellar artery, posterior inferior cerebellar artery, posterior cerebellar artery, basilar, or the internal carotid artery? No, just see this image first. This is the abducent nerve, and this is the artery which I am questioning right now. So which is this artery which is an approximation to this cranial nerve? The correct answer is anterior inferior cerebellar artery. Oh. So it's for the radiologist. Like radiologists should be vigilant for the clivus and petrous apex, because we have most of the time we have seen somebody having isolated abducent nerve palsy. So the lesion is somewhere in the clivus or at the skull base, which is at the petrous apex. So it's important to note that the abducent nerve runs along the entire length of the clivus. And although the abducent nerve lies near the anterior inferior cerebellar artery and it has a similar caliber, which I have shown you in the previous image, Thus, two structures course in orthogonal directions, and that's why they can easily distinguish from each other, because the anterior inferior cerebellar artery, the way it is running, over here you can see this is the anterior inferior cerebellar artery. So the abducent nerve won't be running like this. It has to go straight into the Dorilus canal. So when we are talking about cranial nerve 7th and 8th, so again I'm not talking about from where they originate and how they look, how where their nuclei are. I am just telling you about the radiological anatomy. So for learning about the 7th and 8th cranial nerve anatomical imaging, so they run into the cerebellopontine angle, and then they enter into the internal acoustic canal. They are just along, they are running parallel to each other, but how you can differentiate which one is the facial nerve and which one is the cochlear nerve, which one is the vestibular nerve, because you are actually dealing with the four segments of the cranial nerve. Facial nerve is a single cranial nerve, but the vestibulocochlear nerve are dividing into the cochlear, and again the vestibular is dividing into the superior vestibular and the inferior vestibular part. For that you have mnemonic, but for the orientation of these nerve you need an oblique imaging to remember, to see which nerve is which one. So always remember 7 up coke down is a useful mnemonic to understand the orientation of 7th and 8th cranial nerves in the internal auditory canal. So the 7th nerve is anterior superior, cochlear nerve is anterior inferior, because I said coke down. 7 up, the 7th cranial nerve is anterior superior, cochlear nerve is anterior inferior, and the superior vestibular nerve is posterior superior, and inferior vestibular nerve is posterior inferior. Now I can show you the image. So here is the image, and this image I have taken from the StatDX. So there is a crest or a very thin bracket-like structure within the internal acoustic canal, and that is actually dividing it. It's dividing the canal halfway into the superior and the inferior portions. So through the superior part, this is the area for the facial nerve. Below it is the cochlear nerve, and in the posterior part, these are the two vestibular nerve, superior vestibular nerve and the inferior vestibular nerve. So sometimes we as radiologists, we have to tell if there is a lesion within the internal acoustic canal, and it is whether it is involving the facial nerve or whether it is involving the cochlear nerve. It's very important to tell on the imaging. So that's why coronal oblique stereo state sequences help us in identify the involvement of which segment of the 7 and 8 is involved by the lesion. So I have joined the 9th and 10th cranial nerve, glossopharyngeal and vagus nerve, because both of them are at the cerebellomedullary system. This is the lateral cerebellomedullary system, and both of them run in this system, but it's difficult to identify both of them on the axial plane. Which one is the glossopharyngeal, which one is the vagus? It's difficult to identify on the axial plane. For that, you need either sagittal or the oblique imaging, because the glossopharyngeal nerve is above the vagus nerve, and they follow the same pathway, because both of them, they run along the cerebellomedullary system and then they enter into the jugular foramen. But the glossopharyngeal nerve remains anterior to the vagus nerve in the jugular foramen. The important thing about the glossopharyngeal nerve is the flocculus of the cerebellum. Flocculus of the cerebellum is the normal structure, is a normal lobule of the cerebellum, and never ever misinterpret flocculus of the cerebellum, which is abutting the glossopharyngeal nerve, as any abnormality. It's a normal cerebellar lobule which abuts the glossopharyngeal nerve. The accessory nerve, the important thing about the accessory nerve is like it has cranial parts and the spinal parts. So the cranial parts They are parallel at the level of the lower brainstem, and the spinal parts, they come from the upper cervical segments, then they run along the foramen of magnum, and then they enter into the posterior cerebellomedullary cistern, and then the spinal part and the cranial part, they join at the lateral cerebellomedullary cistern, and again they exit the skull through the jugular foramen. They are posterior to the vagus nerve. In the jugular foramen, the glossopharyngeal nerve is anteriormost, then vagus nerve, and then the accessory nerve. Hypoglossal nerve, which is the 12th nerve, it's also important structure. And how to identify the hypoglossal nerve on the MRI? For that, what I do, I usually prefer to see the vertebral arteries and the posterior inferior cerebellar artery. If you are able to locate them, then you can see that these are very thin structure, thin gray lines, which are entering into this fissure, or you can say it's into the canal. So that's the hypoglossal nerve. So when you are looking for the hypoglossal nerve, look at the vertebral artery and the posterior inferior cerebellar artery, and the thin thread-like structure which is going into the canal, which is the hypoglossal canal, is the hypoglossal nerve. So this is overall summary. I didn't know I have finished earlier. So these are all MRI sequences, and this is the CT scan. So it's for the evaluation of the cranial nerve, always remember MR and CT scan, both are equally important. Because on MRI you are looking at the cranial nerve itself, but on the CT scan you are looking at their exit foramens. So we have seen the olfactory nerve, and the tip to evaluate the olfactory nerve was never misinterpret it from the gyrus rectus. And if you are wondering whether this is gyrus rectus or the olfactory nerve, then go to the coronal sequences. Optic nerve, in optic nerve, we understood that in the optic nerve, the main thing is to evaluate the canalicular segment, because it is often overlooked. The oculomotor nerve, we learned that it runs into the interpeduncular cistern. So remember the interpeduncular cistern, and the structure which is running anterior to it or arising in between the peduncles is the oculomotor nerve. Then for the trochlear nerve, we recall it's the only cranial nerve which arises from the dorsal aspect of the brainstem. For the trigeminal nerve is the largest nerve, or you can remember this any cranial nerve which is entering into this whitish structure, which is the Meckel's cave. For the sixth nerve, these are two thread-like which rise from the pons, and then they enters into the Doralus canals. 7 and 8, easy to see because they have cochlear and semicircular canals along with it at their ends. It's difficult to call which one is the vagus nerve and which one is the glossopharyngeal nerve on the axial sequences, but for the confirmation you can review oblique or the sagittal images. And these are the spinal accessory nerves, accessory nerve, and then this is the hypoglossal nerve. For that you have to remember you have to see the vertebrals and the posterior inferior cerebellar artery and at the level of the hypoglossal canals. Similarly, we talked about the CT scan. CT scan, this is the cribriform plate. It's very important not for the evaluation of the olfactory nerve, but you always have to see cribriform plate in patients of trauma if they have CSF leak. Second one was the optic nerve, so you should know where is the optic canal. And the superior orbital fissure, multiple cranial nerves are using it as the exit foramen. Then the foramen ovale for the mandibular division of the trigeminal nerve, it's also very important. Then this one is the facial canal. Actually, this is showing the facial canal. These are two internal acoustic canal, bony internal acoustic canals. This one is the jugular foramen, anterior to is the carotid foramen, and then this one is the hypoglossal canal on the CT scan, and you can see how thin and faint it is visualized on the MRI. So my last question for today's session was, which cranial nerves run in cerebellomedullary system? Option 1 is 9, 10th, 11. Option 2 is 1, 2, 3. Third option is 4, 9, 5th. Fourth option is 6th, 7th, 8th. And fifth option is 12, 1 and 2. Yes, the correct answer is 9, 10th, and 11th. Glossopharyngeal, vagus, and the accessory nerve. Okay, so the result is in front of you. Ambriel, Ashley, Nimra, and I don't know who is MMK.